Thank you so much for that introduction. Hi, everyone. My name is Shelby, and I will be presenting a study that was published in The Lancet in September of 2023. The study was titled Oral Emergency Contraception with Levonorgestrel plus Piroxicam, a randomized double-blind placebo-controlled trial. Oops. There we go. A little background, as we may all know, emergency contraception is used to prevent unwanted pregnancy. Right now, the most widely used is the oral hormonal type of emergency contraception, either a single dose of levonorgestrel, 1.5 milligrams to be taken within 72 hours, or a single dose of ulipristal acetate, 30 milligrams to be taken within 120 hours of unprotected sexual intercourse. Emergency contraception is not effective after ovulation due to its mechanism of action. It works by inhibiting or delaying the luteinizing hormone surge, which disrupts ovulation. Therefore, it has no effect on fertilization and embryo implantation. But studies have shown that prostaglandins are involved in ovulation, fertilization, tubal function, and embryo implantation. So there was some evidence done before this study. One of the studies was an observational study on 8 women. It showed the effect of a single dose of meloxicam plus ulipristal in inducing ovulatory dysfunction. And then there was an interventional study on human or on non-human primates that demonstrated that a 5-day course of meloxicam for emergency contraception resulted in a significant reduction in pregnancy rate compared to without meloxicam. So before this study, there were no known randomized trials that studied the effect of a COX inhibitor alongside emergency contraception in humans. So the study aimed to investigate whether adding a single oral dose of piroxicam, 40 milligrams, with levonorgestrel would improve emergency contraception efficacy. So like I said, the study design, it was a randomized, double-blind, placebo-controlled trial. It took place in Hong Kong at a major sexual and reproductive health service called the Family Planning Association of Hong Kong. The participants, so women who were already attending this health service and they were requesting emergency contraception, were counseled on both types, either levonorgestrel and ulipristal acetate. They were recruited into the study if they chose levonorgestrel and had the following 5 criteria. I'll just briefly go over the criteria. So if they were healthy and over 18, if they were requesting emergency contraception within the 72-hour window of unprotected sexual intercourse, if they had normal menstrual cycle lengths between 24 and 42 days long, if they agreed to abstain from further acts of unprotected sexual intercourse, and were able to follow up over the next 6 weeks. However, women were excluded from the study if they were currently pregnant or breastfeeding, if they had a current or recent use of emergency contraception, greater than 1 episode of unprotected sexual intercourse, presence of an IUD or history of sterilization, and lastly, if they had an allergy to NSAIDs. So women were block randomized to either a Piroxicam group or the placebo group, and all the pills were masked to the women, clinician, and investigators. So they conducted the study by interviewing the women. They gathered their medical, contraceptive, and menstrual history, and they ensured that a negative urine pregnancy test was confirmed before the study started. In the Piroxicam group, they received a single oral dose of levonorgestrel, 1.5 milligrams, together with Piroxicam, 40 milligrams, whereas the placebo group just received the single oral dose of levonorgestrel together with a placebo. Women then followed up about 1 to 2 weeks after their next expected menstrual period, and they were asked whether they had a period or if menstruation had not occurred. If menstruation had not occurred, a pregnancy test was done. If positive, it would indicate a treatment failure. but if menstruation had occurred, they just recorded the bleeding pattern to compare it with previous menstruation. So the primary outcome that they were studying was the percentage of pregnancies prevented. They calculated the number of expected pregnancies minus the number of observed divided over the number of expected. And they gathered the number of expected pregnancies in each group based on Trussell's model. So for the statistical analysis, they used a lot of tests to compare the groups. They used a chi-square test to compare groups for percentage of pregnancies prevented, as well as the occurrence of menstrual changes. They used a logistic regression to compare pregnancy rates between groups, a Fisher's exact test to compare the occurrence of adverse events, a Mann-Whitney U-test to compare continuous variables between the two groups, and lastly, they used a p-value of less than 0.05 was considered statistically significant. So moving on to the results, there were 860 women, 430 in each group that were recruited between August 20th, 2018 and August 30th, 2022. However, they did lose 12 women in each group to follow up. So the percentage of pregnancies prevented, which was the outcome they were looking at, it showed that the Piroxicam group had a 94.7% of the percentage of pregnancies prevented compared to only 63.4% in the placebo group. So that was a p-value of less than 0.0001. Overall, only one of the 418 women in the Piroxicam group were pregnant, compared with 7 in the placebo group. They found that there was no significant difference in the adverse events or changes in menstrual patterns. So this is kind of what I just went over, comparing each group in the results. They expected 19 pregnancies in the Piroxicam group and only got 1. And then in the placebo group, they expected 19.1 pregnancies and they observed 7. And then this is just showing, this is the menstrual patterns, and they just showed that there is no statistical significant difference between groups. Same here. And then this was the adverse events, same, no significant difference between the two groups. As you can see, both groups had kind of high rates of nausea, fatigue, breast tenderness, and lower abdominal pain. So for the discussion, Piroxicam Levonorgestrel co-treatment, they found that it resulted in a significantly higher efficacy in preventing pregnancy, as well as significantly lower failure rate than just the Levonorgestrel alone. Like I said, the Piroxicam group, they found that there was no increased disturbance in menstrual patterns or adverse events side effect profile compared with just the Levonorgestrel alone. And Piroxicam was chosen over other COX inhibitors due to it's one of the longest acting COX inhibitors available with a very long half-life, as well as it's easily available and accessible. And then same with Levonorgestrel, it was chosen over other emergency contraceptive options like the copper IUD or ulipristal acetate because it's more widely available and accessible. So yeah, they found, they postulate that the Piroxicam offered a synergistic contraceptive effect from like a post-ovulatory mechanism on top of already the ovulatory mechanism that you're getting from the Levonorgestrel. So they concluded that they would need further studies to investigate Piroxicam's effects on fertilization, tubal function, and implantation. They identified that one of the limitations was generalizability because, like when I went over the exclusion criteria, women were excluded if they had current or recent use of hormonal contraception, or if they had more than one episode of unprotected sexual intercourse, which those are not uncommon in clinical practice, so they're not certain if if this will be equally effective when applied to women who had those factors. So in conclusion, they think that piroxicam could be considered clinically when levonorgestrel emergency contraception is the option of choice. And here are my references. And do anyone have any questions?